They say knowledge is power, but you need the wisdom to understand what this actually means. Welcome to the Decoding Health podcast. I am your host, Dr. Urban A. Kiernan. Each week, we will share the stage with renowned experts as we dismantle the black box of knowledge and unravel the complexities of science and its practical applications in our daily life. This show is committed to illuminating topics ranging from personal health and wellness to cutting-edge biopharmaceutical advancements and beyond. Let's get started. Hey everybody, welcome back to another fun and exciting episode of the Decoding Health podcast. In case you don't know who I am Dr. Urban A. Kiernan. I am your host for the next hour, and we've got a wonderful guest today, Dr. Micah Olson. Dr. Olson is we're based here in Phoenix. He's a third generation Phoenician, but he's one of the Valley's most trusted hormonal experts. Homegrown, as I already stated, got his MD from University of Arizona College of Medicine, ended up at Phoenix Children's Hospital over in endocrinology, led their obesity clinic over there in endocrine, was one of Phoenix Magazine's regular top docs on their annual list, and NIH award recipient, co-authored multiple peer-reviewed publications, but has transitioned in life. He is now the founder of Valley Healthspan here in is it in Phoenix or in Scottsdale?
In Phoenix. Yeah.
In Phoenix, Arizona. So, Micah, welcome to the show.
Great to be here.
And let's talk a little bit more about you, your background, what got you into medicine, and then this whole career change. What does this involve?
Yeah. Well, I got into medicine a long time ago because I just had a dream to take care of kids. I thought that would be the coolest job in the world. I loved my pediatrician growing up. I was, fairly good at science and just thought, how fun would it be to take care of kids for my career? So I went into medical school wanting to do that, and that's in fact what I did. I did a residency in pediatrics, and then further subspecialized in pediatric endocrine, and had a career for 13 years at Phoenix Children's and loved every minute of it. Have really enjoyed taking care of kids and endocrine disorders, and my specific area of interest has been in obesity and metabolic syndrome in pediatrics. But over the last year or two, my interests have kind of taken a pivot, and so that's what's led me to my new career adventure.
Got you. So let's talk about your pivot here, and this is extremely personal, and I know there's people who are watching right now that this is going to be wow. It hits home. So to go from taking care of kids to essentially taking care of you, can you share that story as to what happened?
Sure. So, probably close to 10 years ago or so, my mother was diagnosed with Alzheimer's disease. And as everybody knows, it's a life-changing diagnosis, but she was diagnosed in her early 60s, so she was very young. She was otherwise completely healthy. She was the picture of health, and anything that you would want to do to try to prevent Alzheimer's, she was doing it already without even knowing she had risks. So she was very healthy, and in her early 60s started to experience some trouble with her memory. And, we went through a large evaluation, and sure enough, she had Alzheimer's, and unfortunately she passed away a couple years ago. But in the course of her evaluation, she was discovered to be homozygous for the ApoE4 gene. And as you probably know, that's a gene that is very famous for its connection with Alzheimer's disease. And it puts you probably 10 to 12% or so times increased risk. And it's really the context by which you see diagnoses in the early 60s like she had.
Gotcha. Before you move on with the story, just so that the readers know, you said homozygous for ApoE4. Yeah. What exactly does that mean?
So it means she has two copies. All of us have 46 genes. We have 2 times 23. So we get one from one of the 23 genes from mom, one of the 23 genes from dad. And so she had the same copy, this ApoE4 allele. She had the same she got it, from mom and dad. So she had two copies. And so that's the context that you see this incredibly high increased risk for Alzheimer's, and not just Alzheimer's disease, but a younger onset of Alzheimer's.
Gotcha. So in case anybody is familiar with 23andMe, and it's not a plug for them, that's where the name comes from, just to go and put everything in context. So your mom was, her mom and dad gave her this genetic deck of cards that unfortunately worked against her. It is what it is. And then she got sick, ultimately passed away because of the disease. And I think it's important for our listeners to put how devastating Alzheimer's disease actually is. Like, a lot of people joke, "Oh, I'm forgetful. I can't remember where my keys are. I'm developing Alzheimer's." And it's like, okay, that's all said in fun, but what is it like to? And again, if like, I don't want this to be emotional or traumatic, but it is the sixth leading cause of death in the United States. How many million in the U.S.?
Oh, I don't know.
Yeah, well, they're expecting worldwide 50 million by 2030.
Wow.
That's a lot of people who are losing their keys. And again, I'm trying to make light of a horrible situation to see a loved one just degrade.
Yeah.
Well,
as everybody knows, it's a devastating diagnosis. And the first thing you think about is memory loss, and that absolutely does occur. But I think what surprised me, even coming from the medical field, was it was much broader than just memory loss. You get a loss of just your ability to reason well, and also personality changes as the disease progresses. Sure. Really are marked. So at some point along the way, you have a mother, a grandmother, a loved one that is just simply not acting from a social or personality standpoint like they ever did their whole life. And they're saying things they would have never said. They're using language they would have never used. They're, there's anger, there's so many different emotions that they display that's not the loved one that you knew. And that is, from our family, that was probably the hardest thing, was just watching them go down this road and not knowing that there was nothing we could do to help that slide that was going to be inevitable, not just from a memory standpoint, but really from a personality standpoint as well. You lose that person.
And experiencing that firsthand, is that change of personality, is it just like constant, or is it off and on?
No, it's really off and on, and which makes it, it's so erratic and makes it hard to predict.
Sure. So, again, I totally feel for you on this. So now, as Dr. Olson already explained, your mom got the ApoE4 gene, both from mom and dad, and now, okay, you're the product of your mom. What did that mean for you as an individual?
Yeah, so I knew I was at least heterozygous for ApoE4. Heterozygous means one copy of the gene. I knew because my mother had both copies that I would get one from her for sure. Then the question would be, what do I get from dad's side of the family? So I did get genetic testing. And thankfully, I am just heterozygous, which means one copy, not two copies of the gene. So I did get that piece of information, which still, as you know, leads to increased risk. Yep. It is not nearly as high of a risk, thankfully, as homozygous, but generally it's about a 3 times risk compared to the general population, which is still very significant.
Yeah. So just for perspective, compared to the normal type of that gene, if you are heterozygous, you've got a normal and then a dysfunctional. Because of my research with my company, iMetabolic Biopharma, 3.7 times more likely in the heterozygous to form, it's called late onset Alzheimer's disease load, but in reality, these individuals are quite early in life for developing the disease. So 3.7 times more likely having one copy of the gene. If you have both copies of the gene, the homozygous, you are 12 times more likely to develop the Alzheimer's disease. And again, it's absolutely devastating. And, worst off, there's no therapeutic intervention. And I know there's people out here who are watching right now. Well, what about the latest approvals from Biogen, Eisai with Leqembi? If you're ApoE4, you can't take that drug. Your risk of stroking off of that drug is so high that you can't take it. Long story short. So here you are, sitting on this couch with me. You're at higher risk. How did that influence your career choice?
Yeah, so here I am. I'm in my 40s. I'm otherwise a healthy guy. And so it just got me thinking, okay, I've got 3 times higher risk. I've just watched my mother be diagnosed in her early 60s and go down this awful road that eventually led to her passing away a couple of years ago. So the question becomes, obviously, what can I do in my 40s to prevent this from happening? Is there anything I can do? And so as I went down this road, it turns out, I think, if you went back 10 years, the standard answer you would have gotten from any neurologist would be, well, unfortunately, there's nothing you can do. It's just if it's going to happen, it's going to happen. But that has changed. That thinking has very much evolved over the last 5 to 10 years. And obviously, there's nothing foolproof that we have for somebody like me. But there's a lot of things that we think from a lifestyle standpoint, from a supplement standpoint, from treating risk factor standpoint, like high blood pressure, where we can kind of shave off risk here, a little bit here, a little bit here. And we think we can, we think dramatically decrease the risk for somebody like me in my 40s, 20, 30 years down the line, potentially up to 30 to 40% decreased risk through various lifestyle measures. So as I went down that road, one, I was just completely engrossed, because this is personal, in everything that you can do to improve cognitive health and hopefully maintain cognitive health. But so many of those things that we can do for cognitive health, they really extend beyond just brain health. It extends to increasing your quality of life, your physical function, and just your overall vitality as you age. So it really led me down this path of, well, there's this burgeoning area of science of longevity, basically, and improving our quality of life, not just how long we live, but improving our quality of life as we age. So as I went down that road, I just got completely fascinated with it. And it turns out it was a lot of the stuff that I'd kind of specialized in pediatrics really translated to this area. So I've run the obesity clinic at Phoenix Children's, the last 10 to 12 years or so. So lifestyle, nutrition, fitness, and pharmacotherapy drugs for obesity have been my area of interest. And those same lifestyle factors in terms of exercise and nutrition and in reducing metabolic risk really translate into improving cognitive health. And then the other big area is hormones and hormone replacement therapy. Mm-hmm. And I had no idea how to do that for an adult, but hormones are my specialty in pediatrics as an endocrinologist. And so I've had this foundation of an interest in endocrinology and hormones, and that's really helped me to springboard into understanding its use in the adult world. So it's a combination of lifestyle factors, whether that's fitness, whether that's nutrition, whether that's sleep on the one hand, and then kind of hormone optimization on the other, have been areas that I kind of had a foundation for. And the more I learned about it, I thought, man, I need to do this for people like myself, kind of people in their 40s, 40s through 60s, I would say, is kind of the sweet spot of, okay, I want to set myself up to have as much quality of life for as long as possible. How do I do that if I'm otherwise healthy in my 40s? How do I put that investment in for the future so that 20 years from now, I can prevent so many of these preventable diseases like type 2 diabetes, like I'm not going to call Alzheimer's preventable, but I can certainly improve my risk in terms of improving my cognitive health, heart disease, and it's a long list, but I want to set myself up and I want to help other people set themselves up for having as high of quality of life, as high as physical function, as high of cognitive function for as long as possible.
Okay, so you made an interesting point there regarding, in the prevention of Alzheimer's disease. Now, there is a huge association with the development of obesity, with the development of Alzheimer's disease, and there's other parts of the world where obesity is just going rampant, and they're predicting, I want to say by 2030. This is where a lot of those projections are like ending up right now in the world is 2030. That's where the goals on these things are. A 600% increase in that in that particular geography, an increase in Alzheimer's disease. So obviously there are genetic aspects to it, and one of those genetic aspects is this ApoE4 that we had talked about. And again, your genes are your genes. There's nothing you can do about that. That doesn't mean that it's going to result in the ultimate development of the gene. It's the same thing with cancer. It's like breast cancer. There's the BRCA gene. And just because you're a carrier of that doesn't mean you're necessarily going to get it. But you can still get it even without having the gene. And, at least it's clear to me, and we can debate this if you want to, the association with just poor lifestyle, poor diet. You mentioned sleep and like the whole lymphatic system and Dr. Olson, you said like 10 years ago, there's a lot of this stuff that, they just didn't know. Basically in the Alzheimer's space, anything over 10 years old is outdated. And even some of the stuff that's 5 years old is outdated. It's a huge area of growing research, but with that level of expansion of knowledge, there's a lot of confusion onto what to do. So as a part of this change in your career, in developing, an understanding of you, and again, it might sound self-serving, but okay, you want the best for you. I don't blame you. It's like you are responsible for yourself that's out there. And now you came to the realization, well, here's a program that we can help a lot of other people in a very holistic standpoint. It applies to more than just individuals who happen to be like, I did 23andMe and I found out that I'm ApoE4 heterozygous because they do run that test for you as a part of their panel. And it's just a one-time fee for that. You don't need to have the regular subscription for that one. Again, it's not a plug for 23andMe. It's a way for you to get information so Valley Healthspan and what you're providing. It's not just for people with ApoE. It's for any person who is getting older, which I do believe is everybody. Right?
Absolutely. So our goal at Valley Healthspan, which is the new clinic that I am starting, is to help people achieve the goals that I was talking about. And the way we will do that is we will do a comprehensive metabolic and hormone evaluation. We may include genetic testing as well for those that are interested. That can be a touchy subject, so that won't be for everybody, but we can include that as well. So comprehensive lab evaluation. In addition to that, we will want to look at body composition through a DEXA scan, which provides an enormous piece of the puzzle in terms of not just looking at body mass index and using body mass index to define overweight or obesity. You want to take a step beyond BMI and be able to look at somebody's muscle mass breakdown versus fat mass. And when we look at fat mass, we want to be able to look at the difference between visceral fat, which is kind of the fat you store in your tummy area, versus subcutaneous fat, because there's a big difference metabolically. The visceral fat is going to be much less healthy metabolically, whereas the subcutaneous fat is going to be not necessarily bad for your metabolic health.
Maybe a lot of our listeners don't understand basics of anatomy. You're saying subcutaneous fat. Are you talking about like love handles? Is that what that is? Or?
Generally, yeah, your subcutaneous fat is usually thought of as kind of in the buttocks area, the hip area, but really it's everywhere else besides kind of your tummy area, that classic beer belly look, and also kind of the fat that surrounds the organs, like your liver fat or pancreas fat. All that's more in the category of visceral fat, but really everywhere else it is more that subcutaneous fat.
Gotcha. And you said that the visceral fat, the stuff that's on the inside that you can't see, is more detrimental than your pants size, which you guys will. Well, most assessments, they do use waist size as a part of that assessment, but that's a trap. And now you mentioned doing a DEXA scan.
Yeah.
How exactly does that work? It's obviously it's not you're stepping on a scale.
Right. It's a fairly easy test. You lay on a little bed. It probably takes a couple minutes, and you get a little bit of radiation, but it's thought to be about 1/100th the radiation that you would get from a cross-country airline flight. So it's really a very low amount of radiation, very quick test, and then you have your results. It looks at bone strength, looks at muscle mass, looks at the breakdown of your fat mass as well.
Gotcha. And ultimately, why would that be important? Just to give perspective on things, because here in the U.S., everybody is so scale oriented. There's a place that is, like, I don't want to say the name, but it's something Watchers, and just in the name, it's implied is all about stepping on a scale.
Yeah,
and that. Again, that's a trap in itself. There's some people who will be more healthy who weigh 10 pounds higher because of a change in body composition, because muscle is more dense than fat is. Why should all of this really, really matter?
Yeah, that's exactly right. So, BMI, body mass index, is a weight-based measure, and it's useful. It's especially useful on a population level. On an individual level, it can really lead you astray. So you got to get beyond just looking at BMI for the reasons you mentioned. BMI can overestimate somebody's risk in some cases. If you can have somebody whose weight is, think of a middle linebacker in the NFL. They have a lot of muscle mass.
Sure.
I guarantee you their BMI would be put in the obese range if you're just looking at BMI, but that absolutely does not mean that they are metabolically unhealthy. I'm sure that person is very metabolically healthy because they have a lot of muscle mass and not a lot of fat mass. So BMI is very misleading in that circumstance. The other circumstance that's probably a little bit more subtle is that you can have, let's take away the muscle mass issue for a second, and get back into that visceral fat versus subcutaneous fat. There are people that are thin that have a normal BMI, and yet when they gain weight, all that weight, they really don't have a capacity to put weight in the subcutaneous space. Their weight gain goes straight to that visceral fat. And so you can have somebody who's relatively thin, but they have visceral fat. They put weight on in the stomach area, that waist circumference area, and they can be very metabolically unhealthy, and you may not even realize it until you do the testing. And conversely, there are people that really have a capacity to gain a lot of weight in the subcutaneous space, and they can gain weight, and it's fat, not muscle, and yet they remain fairly metabolically healthy. There's those people too. You hear this term, metabolically healthy obese. So BMI, there's clearly a correlation between BMI and health, but it is not a one-to-one correlation by any means. And so the DEXA scan, in addition to your laboratory, in addition to getting to know the patient and family history and so on, gives a much better picture of somebody's risk factors and their overall metabolic health than just looking at straight BMI or weight.
Gotcha. And so what I'm getting from you is this is a very personalized approach.
Yeah.
And we'll get into the little intricacies of that a little bit more. But with the lab results, are you just talking about like a comprehensive like metabolic panel? Are you talking like a lipid panel, or is it more in depth than that? And can you describe that a little bit further in terms of what are these hormones that you're looking at?
So the beauty of what I'm hoping to be able to do is that we can take a much deeper dive, both from a laboratory and imaging assessment, but also just spending time with patients. Your typical doctor's visit is like 15 minutes,
if you're lucky.
If you're lucky. And that's what's termed sick care. What we're trying to do is what we term well care. So it's preventative. And to do that well, it just takes time. You have to have time to get to know the patient. You have to get to know their story. You have to get to know their family history. And you have to get to know what their preferences are and what it is that they want out of the visit and out of life in general. So those things take time. You just simply can't do that in 15 minutes. And so we will have the luxury of both spending the time with the patient, but also doing a much broader laboratory panel than what you would typically get at your doctor's office. Now, this gets into the criticism of that is, well, we're driving up healthcare costs. That's too expensive. Those things are not necessary. But the counter argument is, take somebody who's, I'll just use myself an example, somebody who's in their 40s, and yes, they may not have type 2 diabetes, they may not have heart disease, but the whole goal at this stage of life is, okay, how do I set myself up to not get those things? What are my risk factors? How far down the road am I to developing these things? And what can I do from a precision medicine standpoint to set myself up to not get those things over the next 20, 30, potentially longer than that? And so to look at this from a sick care, not a sick care model, but a well care model, is all about prevention. And we have to have this information so that we can set up an appropriate individualized plan for that patient and we have to know exactly where are those risk factors, what is their body composition. We'll look at other things like a VO2 max test, a fitness test as well, so that we can do our best to optimize this patient's journey over the next, how many decades, and really set them up for a high quality of life.
Okay, so you used a term there, precision medicine. For somebody who doesn't know what that means, what does that mean?
Yeah, it's a little bit of a buzzword term, and it's something that I think we're still struggling to understand how to incorporate this into just everyday medical care. But basically what it means is every person has a unique set of genetic factors, lifestyle, environmental factors, and biology, physiologic factors. So when we do all these great big randomized controlled trials that we do that drive the decision making for medical protocols for statins and blood pressure medications and so many other things that we do in medicine, when we do those look at means, population means, and we are setting up our recommendations for the mean from that randomized control trial, the middle of the road.
Like in the average?
The average, exactly.
Okay.
So sorry, yeah, mean, average. And that's what those trials allow us to do. But the truth is, all of us are individuals. We're all different. Exactly.
You and I are different? Do we look different? I don't know.
And so in medicine, we've really gone away from treating the individual and just going to kind of these protocolized, here's what the randomized control trial, here's what the mean was, and we're going to do everything based on the mean, because that's what the randomized control trial speaks to. So it's really a movement back to, okay, we want to look at the patient as an individual and understand all the, genetically, physiologically, culturally, environmentally, what is unique about that patient, and not just what all those things are, but what's that patient's preferences. And all those things are going to inform a much more specific to the person, customized plan for an individual than a cookie cutter, kind of protocolized approach that you can get from the randomized control trials. So we take the randomized control trials. There's no question about it.
Right.
But that's one piece of the puzzle.
Yes.
And in my opinion, the larger piece is really drilling in on that person themselves and understanding what it is that makes them different in what their values are and what their objectives are.
I'd like to take a moment to thank one of our sponsors, Foresight Chiropractic. Foresight Chiropractic is a wellness clinic providing specialized care to maximize your human performance. Their cutting-edge techniques are gentle, non-invasive, and customized to you. Dr. Lavender and his team are committed to giving you the care you need to help you heal faster, feel better, and perform better than ever before. Find them online at foresightchiropractic.com. and mention this podcast when you schedule to get a free consultation and discounted nervous system exam. Again, that's foresightchiropractic.com. No, this is absolutely awesome, especially with my background and understanding around the system. And I understand why it's geared towards the population aspect, because there's a lot of people that are out there. But I think it's really interesting that as a part of that whole list of aspects that you put into the different categories of things that you look at, you actually said culturally. Can you elaborate on any specifics on that? Because I think it's there from a cultural standpoint, which is also like ethnic, there are certain disease aspects that run within certain, I'm using all of these political correct scientific terms, like within specific demographics, you get these different things. But again, it just comes back down to, who's your mom and dad and who is their mom and dad. And it's a lot of populations grow up in genetic isolation. If you turn back the clock 200 years, it's not the melting pot that we have here. Can you comment a little bit on that?
Well, really, yeah, I brought that up more to speak to somebody's preferences and what their goals are. So, I think science can give you information and can help you make decisions, but it cannot tell you, I would say this about science, I would say this about, a medical application of science. It can't tell you the right thing to do. All of us as individuals have and this comes from our cultural preferences, and you can go beyond cultural to say, religious or philosophical or whatever. I'm using cultural as kind of a catch-all term, but that's what really drives somebody's preferences. And so there's so many decisions that we make in medicine that are not black and white. It's true, the more science we have, the more knowledge we can say, well, here's if you do this, you'll have this percentage risk. If you do this, you'll have this percentage risk. So science can speak to all those things. But what it can't do is say, hey, I value, my eating this type of food more than eating this type of food or this way and I don't, even if it affects my risk negatively or positively for something, I will take that because I value this type of eating. And you can, I use diet as an example, but anything that we think of in life, whether it's how much sleep we get, whether it's the type of exercise that we do, whether it's how we spend our time, hanging out with friends or what we do with our family, all those things have health consequences. And I want to get to know a patient so that I can incorporate their values from those things that do stem from culture, and have that speak to the medical decisions that we're going to make in terms of risks we're going to take with medications, risks we're going to take with supplements, risks we're going to take with whatever lifestyle choices that we recommend. So all that has to blend together. So I guess when I use culture, I mean just kind of getting to know somebody's preferences and what they value within this broader context of medicine.
Gotcha. No. Thanks for clarifying. My whole angle on that, like when you were talking about like the lean, metabolically incompetent, challenged individuals. Southern Asian or Indo-Asian individuals, especially the males. Like most East Indian males are on a statin because they are just predisposed because of their genetics from over there. And many of them are very, very lean, but their cholesterol is out of the roof. And it's because that's a clear, cultural ethnic group where it's that visceral fat. Like they've got what's known as non-alcoholic fatty liver disease, or NAFLD, runs rampant within that population, and it's real. And so you're engaging in a group of people 40 and older who have experienced life, make a lot more decisions, and especially in your case, like looking at you, it's like you're a healthy looking individual. Like I can't comment on the inside, like metabolically what you're doing, but at least from initial perspective, I wouldn't give you a second look like, wow, he's, somebody go and get the coffin ready because, he's ready to keel over. I'm sorry if that sounds insensitive, but you're all thinking, exactly what I'm talking about. You're thinking the exact same thing that I'm talking about, but you've led a healthy lifestyle, and now you're modifying on top of that because of your particular situation.
Right.
Now, coming back from the pediatric standpoint, dealing with the obesity clinic, and we are now in this really, it's a really effed up time. Right now. Here in the state of Arizona, I just mentioned NAFLD, youngest case down in Tucson, 8 years old. This is a disease that 40 years ago didn't even exist here in the United States. And it's 50% of some demographics now. Like it's absolutely horrible. And so now you've got this whole generation of kids who are dealing with diseases that they shouldn't be dealing with until they're our age. It shouldn't be manifesting into this point in time. And so, I've already stated, like, there's this association with obesity and Alzheimer's disease. And now you've got this whole group of kids that, they haven't even reached adulthood, and the cards are stacked against them. How is it that what you're talking about is something to go and, just a message to, say a person comes into your clinic because they're worried about their aging and their health. Is this something that they can translate in terms of education, choices, behaviors, even into children, so that it makes, obviously business is business, but from a caring health care, a wellness standpoint, you've got a group of children that actually have a shot at a future?
Well, so I started medical school 25 years ago, and I remember clear as day in those first 2 years, or when you go through all your lectures, and I remember a professor saying that type 2 diabetes does not occur in children. And that at the time was true. The first reports I think that we have of type 2 in kids is probably back in the 1990s. So we just that was a very true statement, and the amount that it has changed in those 25 years just is completely astounding to me. So as a pediatric endocrinologist, we would see probably 100 to 200 new diagnoses every year in a center like Phoenix Children's. And that was just simply unheard of 20 to 25 years ago. So we're seeing these disorders because of our obesogenic environment younger and younger. We're not just seeing obesity younger and younger, because we clearly are seeing that in severe obesity younger and younger. We're seeing the metabolic complications like NAFLD, like type 2 diabetes. And I think what I really learned in pediatrics, to kind of tie back to your question, Urban, is that if we in pediatrics targeted the kid with lifestyle recommendations, it was going to go nowhere. That was a recipe. There was a futile effort, because you're not going to tell this 8-year-old or 9-year-old or 10-year-old to eat better and exercise more. You can do it, but it's just not an effective way to do it. That you have to target the family.
Right.
And I always knew if the family was going to change their environment, then the kid had a fighting chance to do well. And if the parents weren't going to do it, there was absolutely no way we could expect the kid to. So I do think, targeting the patients that I will be seeing to the degree that they have children as well, that's the best chance for the kid, is when the parents, the environment that they're in changes, and the parents make this a priority. So I think, targeting the kid is kind of our instinct, but that's really a backwards way to look at it. It's the environment that they're in that needs to change.
Gotcha. And so, long story short, the patient comes in, they want well care.
Yeah.
And they run through the battery of tests. You take the time, do this comprehensive assessment. And so is it just like kind of like a drive-through? You can pop them a pill and then they can go out on their way. Like,
well, I wish. Yeah.
There's no free lunch
Yeah.
at the end of the day. And
Yeah.
Unfortunately, we live in a society where it's like, it's all about convenience and stuff. And,
Yeah.
and right now the craze is some glutathione.
Yeah.
Wegovy.
Yep.
We can go on that. And we both have our unique positions on this. I'm going to assume that that's going to be used as a part of your treatment.
Yeah.
Can you elaborate a little bit on it in terms of that type of approach? Because I think, there are tremendous success stories with that drug, but at the same token too, there are nightmares that go with that drug too. So, maybe as a part of this, can you explain maybe a little bit more regarding your guys' approach and then the responsible way to go about this?
Yeah. So we will absolutely use medications when appropriate. But we will complement that with a very heavy approach on lifestyle. And at the end of the day, if we're going to have success, that's really where I want to major. And that's not to say that we're going to forget appropriate medications, because we will use that. And I'll say for the record, I think the GLP-1s are the drug of the century. I really think that they are that profound and that helpful. But they present some major problems, which you're referring to.
They're being abused, long story short.
For sure, I think that's the case. I mean, the cost is just a problem that we are nowhere near solving, how to deal with the cost. Hopefully, as time goes on, we'll have more competitors and that will drive the cost lower. And I do think that will happen with time. But maybe the broader point is these GLP-1s like semaglutide are incredibly helpful to get weight down. I would say even broader than that, they are helpful from a metabolic standpoint. So you're not just decreasing weight, you are improving insulin resistance, improving type 2 diabetes markers, improving heart disease. They've been shown to do so. That's why I say I really do think they're the drugs of the century. But if I'm in my 40s, do I want to be on a weekly injection for the rest of my life? Should I want to be on that? And I say, well, let's use that for the right person, and I will not hesitate to use that in the right scenario. Sure. But we want to be looking out over the horizon and saying, hey, these meds have great weight loss, but they also, you lose a ton of muscle on them.
40% of that weight loss is muscle wasting.
And
people need to know that.
Back to setting yourself up to aging well and having as much physical function as you can for as long as possible. Losing muscle mass is a big no-no. We want to be doing the opposite. We want to be putting on muscle mass to improve those chances of physical function as we age. So we know that muscle loss, we're already fighting time to begin with. We all lose a certain percentage of our muscle as we age. And so a drug like a GLP-1 is just going to exacerbate that. So there's these things we have to keep in mind, and we're not just targeting the weight loss like so many people are doing. Yep. And I know there's an attraction to that, but our philosophy at Valley Healthspan is, from a weight loss standpoint, is going to be weight loss can be, in many cases, a very appropriate means to an end, but it's never more than that. It's not the end in itself. So yes, a very effective means to an end, but the end itself is not the weight loss. The end itself is your overall health and wellness. Yep. And again, setting yourself up to have as high of a physical and cognitive function as you can as you age. And I do think a dependence on the GLP-1s can work against you from a long-term standpoint, even though I absolutely think they have a role in the short run.
Absolutely. Everything has to have its place. Again, this is a common thing that I say on this show: there is no free lunch. And the simple fact that you can get prescribed a GLP-1 without once speaking to a physician is a huge issue.
That's a travesty.
Yeah, and you're talking about all the benefits, that the good stuff that happens. There's a ton of bad things that could happen too that need to be closely monitored. So let's touch on this now: muscle mass. Like, are we talking about, I want to look like Arnold Schwarzenegger? Or like, no, like seriously, let's put this into perspective. As an endocrinologist, longevity, what is the value of muscle mass as a composition of my body?
Sure. Well, I think number one, you're going to have metabolic benefits from that increase in muscle mass. So it's going to help you improve your risk for, or decrease your risk for developing type 2 diabetes. But over and above the metabolic risk, which is going to help you age better by itself, we want to be able to have as much physical function as we can. So I'm, in my 40s now, I can go up the stairs. I can do a lot of physical things without thinking twice about it. So it's something that for people my age, we really don't think about. But fast forward 30 years,
Sure.
So for somebody who's in their 70s, they've experienced that a lifetime of it's called sarcopenia, the muscle loss that is just part and parcel with aging. And at some point, as you lose that muscle, you lose function, and you can't do some of the everyday things that you want to be able to do. And so, in the Alzheimer's world, we talk about building up a cognitive reserve, which just simply means an increase in education, increase in kind of life experience, so that as you do start to lose cognitive function, it takes longer to get to a point where you're actually symptomatic. And that's an important part of Alzheimer's, preventing Alzheimer's, is building up that cognitive reserve. It's the same concept with muscle mass. The more you build up in the years that you can do that, as you're healthy in your 40s and 50s and 60s, if you can build up as much muscle mass as possible, you build up a reserve. So as you are fighting that aging process and the sarcopenia that comes with it, the more muscle mass you build in these middle-aged years, and the more you're able to move in a functional way that provides stability and provides posture, you're going to be able to do those everyday functions of life that we all want to do.
Sure.
When we're as we get into our elderly years. So the increase in muscle mass and the ability to use that muscle mass through kind of functional movements is an incredibly important part of setting yourself to not just live longer, but have great function and do the things that we all want to do when we're older.
And you're with me personally, you're preaching to the choir. And there's so many clinical studies now that show the benefit of lean muscle mass, not even just from a geriatric standpoint, but in terms of fending off cancer. There's a lot of oncology clinics as a part of their protocols for treatment. They're not putting on your treadmill. They're actually having you lift weights, because they want to preserve that lean muscle mass for all of these metabolic benefits. And even you classified it as subcutaneous and visceral fat. Like in my area of research, there's even like ectopic fat, like ectopic pregnancy, a pregnancy where it doesn't belong. There's fat where it doesn't belong. And even within the cell, there's actually fat T cells that develop. And when that occurs, your immune system is completely compromised, and you have to fight that by basically going on a diet at the cellular level. That's the only way to go and explain it in, from a layman's perspective. And so what you're talking about is the need for maintenance, if not building, of lean muscle mass, lifting weights. I'm going to throw the gender aspect into it. There's a lot of women who don't like lifting weights because they're afraid they're going to look like a guy. Can you comment on that? It's just to help them get over it, because it's for your benefit out there, ladies.
Well, sure. I think the muscle mass increase is every bit as important for females as for males. And I don't think we're not talking about a physique that looks masculine.
Sure.
That's definitely not what we're talking about. And I think there is I'll say this carefully, kind of amount of fitness and muscle building that is very good for your metabolic health and very good for improving your chances for higher physical function with longevity, that remains feminine and not a masculine appearance.
Sure. And, I don't think you said anything that was like borderline in terms of insensitive.
Careful.
No. In long story short, is because of a thing called testosterone. It's like I would say 98% of all female bodybuilders are that way because they're juicing. I'm just going to go and state it that way. It's they've altered their biochemistry chemically in order to achieve that look. So, the moms out there who, they want to go and preserve their longevity, not just for like when the kids are out of the house, but even how do you compete with the kids, in the household. It's like people are starting their families later in life, in their 40s and stuff. And it's like, that takes a ton of energy, being able to keep up with them. So in terms of this holistic package that at Valley Healthspan that you guys are providing from an education standpoint, what else are you providing as a part of that? Is that all in-house, or are there additional resources that you provide to people to just basically understand what they're going through?
We want to help people provide a framework for exercise, and the same will be true for nutrition as well. But I won't be the one sitting there and teaching people how to do a squat or a deadlift or, all these different types of movements that will are going to lead to longevity. So we will partner with folks in the community and have resources outside of our clinic where we want people that can help our patients take the next step and provide accountability, but also provide just the proper training. So you can want to go out and lift weights or start to do these exercises, but the truth is, if you're not used to these things, one, it's a very foreign world that makes people uncomfortable, but two, you can get yourself in trouble by doing too high of an intensity of exercise too quickly, or doing muscle strengthening movements where you're not trained in exactly how to do that. So we'll certainly utilize folks outside of our clinic to help our patients as they start that journey.
And I'm going to throw in one more caveat too. It's normal here in the West that you were young and athletic at one point in time, and then life caught up with you and you fell off the horse, and now you're picking everything up. You're not 25 anymore. and don't BS yourself thinking that, I can just walk in and I can bench 315 because that's what I did back in the day. You're going to hurt yourself.
Right.
You need, like, I know this from firsthand experience, shoulders. Like, as a male, it's like once you hit like mid 30s, like doing like your rotator cuffs just from life, they're toasted. I can't do military press. I got to keep everything on the inside. I've already had one surgery, possibly in the future another surgery on this. And again, that's just life. Don't convince yourself that, oh, I can do this and I can fight through the pain. You're defeating the purpose
Right.
by being put into a sling. So no, this is great that you're providing all of these comprehensive resources. So as of May 1, you guys have opened, correct?
Absolutely. Yeah. So we are eager to seed new patients. And as of May 1, we're open. And we're happy to schedule new patients.
Gotcha. So if somebody wanted to find you, where can they look you up, Dr. Olson?
Yeah. Visit our website at valleyhealthspan.com, and you can also call our clinic. I don't have that number yet. So,
no, that's fine.
Yeah,
that's fine.
So visit our website, valleyhealthspan.com.
Not a problem. And again, too, just this longevity, well care. This is a huge issue in our society. It's one of my biggest criticisms with the way, it's not just here, it's everywhere. It's the way things are done. Again, my livelihood is based in the biopharma industry. But at the same token too, even though my company is innovating drugs, I've got a firm personal commitment to never be a customer. It's my responsibility. And so I just wanted to pass that on to you, the listener, and I hope it's okay for me to speak to you. It comes down to you to go and make these choices, to go and do this. Phenomenal story, making this personal. And again, if this is the first time you've ever heard about this whole ApoE thing, if you guys are familiar with Chris Hemsworth, Thor, you flick too hard for the ladies and stuff. Yeah, you get to see his bum in that particular scene. He's very vocal about his recent diagnosis being also ApoE4, E4. He speaks about it on his Netflix.
Limitless, yeah.
Yeah, Limitless out there. Again, this is real. And so, but there are resources out there for you. So if you're in the Phoenix area, go and look up Dr. Micah Olson, Valley Healthspan. You guys are going to be doing great things. There's other resources online. This is not the last time that we're going to be talking about wellness, talking about Alzheimer's disease and the specific pathologies behind this. Would really love to get you on a later episode on this, especially as your practice evolves.
Yeah.
And additional messages and resources that can be provided to our audience, because this is something that affects all of us. So, with that said, thank you so very much for being on the show. And
great to be here, Urban.
Absolutely.
Thanks for having me.
Looking forward to just seeing you guys grow and expand, because there are so many people who need just this level of personal attention for personal healthcare, because again, we're all individuals on this. So again, if you have any comments or questions, post them below. Dr. Olson and I will both see them. We'll be able to come back and address some of those comments. Like and subscribe. And if there's anything else that you want to see, or want to address Dr. Olson with, feel free to reach out to him, and great things to come. We'll catch you next time.